Hello, good afternoon everybody. Going with the tradition, I'll introduce myself. I am Mavuram Sindhoora. I work as a faculty with the Department of Medicine here. Today let's review about the new guidelines that have been brought out by the American Diabetes Association. Initially brought out in the summer of last year, 2016, got revised with some new recommendations came out earlier this year in January. So just a little bit of introduction regarding the diabetes as a syndrome. The disease burden of diabetes, according to the CDC from 2014, estimated until 2012 statistics shows 29.1 million people, or 9.3% of the population of United States with diabetes. That includes both diagnosed and undiagnosed. Out of which only 21 million people were diagnosed. And this gives prevalence based on the ethnicity, with American Indians, Alaska Natives having 15.9% prevalence. Next by Hispanics, non-Hispanic blacks, Asian Americans, and non-Hispanic whites. So a little bit of background into the guideline development by the ADA. So these guidelines are developed by a professional practice committee, which includes physicians, diabetes educators, dietitians, and in the 2017 guidelines, the committee has been expanded to involve more people or more experts from the field of adult and pediatric endocrinology, epidemiology, public health, including OBGYN, and also people with interest in preconception planning and pregnancy care. So for this current revision of 2017 guidelines, oops, there was a typo there. It was a systematically searched Medline review of all the human studies from January 1st of 2016 to the whole of 2017 that are included in these new guidelines. Sorry for the typo. And then these were reviewed by the executive committee of the board of directors of ADA. They also incorporate feedback from the clinical community. Bit of the ADA evidence grading system, levels of evidence as A, B, C, and E. Level A, which includes evidence from well-conducted multicentral trials and meta-analysis. B is supportive evidence from well-conducted cohort studies and a single well-conducted prospective cohort study or registry, or a well-conducted case control study. And C includes, C is recommended based on supportive evidence from poorly controlled or uncontrolled studies. Those are evidence from randomized controlled trials with one or more major or three or more minor methodological flaws. And E is expert consensus or clinical experience. So we should notice that in 2017 guidelines, there was a huge shift from standards of medical care to standards of care. This has been specifically put forward to address the psychosocial issues which they have stressed a lot in these current guidelines. In all aspects of care, including the self-management, mental health and communication, complications of diabetes and other comorbidities associated with it. So going by the topics on which the guidelines have been discussed, first is the diagnosis and classification of diabetes. Nothing much has changed here. As we see, still HbA1c greater than or equal to 6.5, or fasting plasma glucose greater than or equal to 126, and a 2-hour postprandial with greater than or equal to 200, and a random plasma glucose more than or equal to 200 with symptoms of hyperglycemia. There has been not much change, and as I go forward, I'll make sure that I point out the new recommendations or new changes that came about in the 2017 ones. So A1C, why do we use it and where can't we use it? Let's go over that one. So A1C, we use, it's very convenient because fasting is not required, and it has greater, pre-analytical stability, and it is less influenced by, stress or illness. But limitations, it has lower sensitivity of A1C at the design cutout points. So according to the NHANES, last year they came out that at the lowest level of cutoff point, almost 1/3 of your diabetics, which were otherwise diagnosed by fasting plasma glucose number, were left undiagnosed if you use A1C as your diagnosis. And of course, cost and limited availability. And then there are other factors that affect hemoglobin glycation independent of the glycemic status, which we should consider while interpreting the A1C in relation to the sugars. One of them, your ethnicity, age specifically, because all these recommendations are put forward by studies done in adult population. So we are not sure if it can extrapolate it to the children and adolescents. And ethnicity, African Americans have a baseline higher A1C to begin with. And hemoglobinopathies, like sickle cell traits, where there is hemoglobinopathy but there is no increased cell turnover. Here you should include, you can use A1C that are specifically designed, like assays specifically designed for these type of conditions. And situations where there is increased RBC turnover, like in pregnancy, hemodialysis, recent blood loss or transfusion, or people on erythropoietin therapy, you would want to, you should refrain from using A1C testing as a diagnosis. You can use your fructosamine testing. So the classification, let's start out with pre-diabetes. So pre-diabetes, it was, the term came out in 2013 after many studies from 2011 to 2013. The committee came out with this term pre-diabetes, which includes individuals with IFGs like impaired fasting glucose, meaning fasting glucose between 100 to 125, or an impaired glucose tolerance test that is 2-hour postprandial is 75 gram glucose tolerance test is 140 to 199, or an A1C between 5.7 to 6.4. This is not a clinical entity by itself, but it is a portender of incidence of the probability of development of diabetes in a patient along with the cardiovascular disease. Just to give you an idea as to the risk of developing diabetes in someone with the pre-diabetes that we have detected, it's good to talk to the patients, and then make them aware of how much are they at risk of developing diabetes in the next 5 years, say. So A1Cs between 5 and 6, they have a 5-year risk of the risk of 5-year risk of developing diabetes is anywhere between 9 to 25%, and A1Cs from 6 to 6.5, it is 25 to 50%, which is very significant. So we can start aggressive interventional therapies at this stage, including weight loss or even pharmacotherapy to decrease this risk. So these are all the recommendations when to screen a patient for diabetes. So these are all with B and C with some E level of evidences. So I'll quickly go over to the table here. So any testing, even pre-diabetes testing should be considered in overweight or obese individual defined by a BMI of equal to or more greater than 25 or more than or equal to 23 in Asian Americans who have one or more of these said risk factors, who have a prior A1C testing more than or equal to 5.7, a first degree related with diabetes, which we see is almost everybody, and high risk race like ethnicity, as we went over in the prior slide, and women who had gestational diabetes, history of CVD, hypertension, and high cholesterol and high triglycerides, PCOS, physical inactivity, and other clinical conditions with insulin resistance like severe obesity and acanthosis. And definitely recommended for, should begin at age 45. And so if the results are normal, then the minimum interval that you can wait to test again or repeat the testing is 3 years. So they came out with this 3-year interval based on, again, studies that showed that this 3 years is not with a sufficient time, so that for the false positives need not be checked that often, and the false negatives, we are still are able to catch hold of those false negatives before undue complications. And the same thing to check for diabetes in asymptomatic children less than or equal to 18 years. So we know about the increasing incidence or prevalence of childhood obesity and diabetes. So overweight, again, BMI more than 85th percentile, and weight more than 120% of the ideal for height, and then that plus any 2 of these said detailed out risk factors. Family history of type 2 diabetes in first or second degree relatives, again the same, high risk race, signs of insulin resistance, and specifically maternal history of diabetes or gestational diabetes during the child's gestation. And then age of initiation, we can start screening them at age 10 years or at onset of puberty, and then frequency every 3 years again. So, okay. So there was, because of the recent data, previously we used to screen or delivering a baby weighing more than 9 pounds or more. This is not considered an individual risk factor for screening for prediabetes anymore. So that is one of the guidelines recommendations. And again, these have come up with, apart from these screening tools, the ADA has come up with this diabetes risk tool, a risk test to assess, just like, this is like a clinical test. You don't need any laboratory investigation on this one. So it actually is based on weight, age, sex again, and presence or absence of gestational diabetes, relatives again, and then other risk factors like hypertension and physical inactivity, and the weight, of course. So 5 or higher, who score 5 or higher on this scoring are at a risk of developing diabetes. So then you would initiate either test them again, or you would want to initiate intervention strategies at this point. So classification of diabetes. So this new recommendation have included new diagnosis and classification of type 1 diabetes specifically, because they've come out, because the beta cell dysfunction and the destruction can actually, monitoring those can help us in controlling diabetes type 1 even before they are actually diagnosed with complications like ketoacidosis. So type 1 diabetes, we have 2 different kinds. It's immune mediated, one is idiopathic. Immune mediated is 5 to 10%, and it has islet cell autoantibodies and antibodies, the GAD65, which you're very familiar with, insulin antibodies, tyrosine phosphatases. And this one has a strong HLA association, which could be the protective or predisposing. The second one is the idiopathic one, which has unknown etiology, but it is characterized by permanent insulinopenia and are prone to ketoacidosis. So this could be either transient or permanent. So they have manifestations of ketoacidosis, during times of stress or illness, depending upon so it is not a complete absence of insulin, it's just insulinopenia, but at a more severe level. But they have not been able to detect any evidence of beta cell autoimmunity in this category. Right. So testing for type 1 diabetes again, concentrate on these A recommendations. Presence of 2 or more autoantibodies predict clinical diabetes, and they serve as an indication for intervention in the setting of a clinical trial. So, and then screening for type 1 diabetes with a panel of autoantibodies also. So in the future slides, we'll talk about staging of diabetes type 1, which comes in the next section. So type 2 diabetes are not included here because we already talked about kind of screening for type 2 diabetes is nothing but pre-diabetes or diagnosis. So that's covered there. So gestational diabetes. So here also there were certain changes made. Patients who have a previous diagnosis of diabetes at the time of them being pregnant, they should be screened around 12 to 14 weeks of age, gestational age again. And then test for gestational diabetes at 24 to 28 weeks in previously undiagnosed diabetics. So this is one of the change in recommendation. Postpartum, when to check the patient for the persistence of diabetes, a patient with gestational diabetes, say. So it used to be 6 to 12 weeks postpartum. They changed it to 4 to 12 weeks. It's mainly because of more possibility of catching the patients at their clinic visit. Usually the postpartum visits are scheduled about 4 weeks. So if we initiate screening or testing again at this point of time, there's a higher chance that we can not miss those people. And then again, with the history of gestational diabetes, like we saw earlier, should be screened every 3 years. And history of gestational diabetes, who's been found to have prediabetes postpartum, they should receive intensive lifestyle interventions and metformin. So how to diagnose GDM? Nothing much has changed here. Two different ways, one-step strategy and two-step strategy. One is a fasting, overnight fasting of 8 hours followed by a 75-hour glucose tolerance, glucose load, and then testing 1 hour or 2 hours, 1 hour and 2 hour postprandial. It's 180 and 150 at the cutoff, and the two-step is followed. So with the one-step strategy, they found to have more people, more patients or more pregnant women who fall into this age group, which adds more further burden, and then it has not been shown to affect your improvement in the pregnancy outcome. So they've come up with this two-step strategy where they do a 50-gram glucose test where there was no fasting required, and then do a 1 hour post challenge test. And then if that's positive, then they go ahead and do the 100-gram glucose 3-hour testing. And this is one other area where they've focused on in these new guidelines. It is monogenic diabetes syndromes, where they have also included a table detailing out the most common gene mutations as well as the presentations. So monogenic diabetes, monogenic defects that cause beta cell dysfunction, they are responsible for causing neonatal diabetes and maturity onset diabetes in the young. And they represent a very smaller population, percentage of diabetes populations, less than 5%. So going for the recommendations, all children diagnosed with diabetes in the first 6 months of life should have immediate genetic testing for neonatal diabetes. So this is different from type 1 diabetes, where type 1 diabetes, they usually present after 6 months. And neonatal diabetes are usually, most often they do not present later than 6 months. So here is their first way that you need to screen them. And then children and adults diagnosed in early adulthood who have diabetes, either not characterized with a type 1 or type 2, but have risk factors, then they should be tested for maturity onset diabetes. So again, neonatal diabetes, much less often after 6 months of age. It's almost 80 to 85% of the cases can be found to, they have underlying monogenic cause, and it is either transient or permanent. Again, MODY, characterized by impaired insulin secretion with minimal or no defects in insulin action. And there is an autosomal dominant pattern in the inheritance, and at least 13 genes have been identified. And these are the most common ones, or most commonly reported ones. And then, due importance was given in the guidelines in these two, because there are certain, this GCK MODY, the MODY type 2, or that's what they call. Here, actually, there is no intervention necessary apart from regular screening or regular checkups of your blood glucose at the doctor's visits. And of course, lifestyle interventions at all stages. And then the other, this one, HNF1A, actually, they found that sulfonylureas, when used in the treatment, have been shown to be beneficial. So, this is another newly added one, is cystic fibrosis-related diabetes. We used to see at least a fairly amount of cystic fibrosis population in the hospital. So this one occurs about in 20% of adolescents and 40 to 50% of the adults, and this incidence has been, this prevalence has been gradually decreasing. So, so patient with cystic fibrosis related diabetes should be treated with insulin to attain the glycemic. That's an level A recommendation. And then A1C as a screening test for cystic fibrosis is usually not recommended. And again, annual screening should begin by age 10 years. This is something else that they've added to. This is post-transplantation diabetes mellitus, and the other term is new onset of diabetes after transplantation is NODAT. So here, they suggest that, after the usual expected range of hypoglycemias immediately after the transplant, say usually let's say after the 4 weeks, let's say 4 weeks, you would want to do the the glucose challenge test to make a diagnosis of the post-transplantation diabetes mellitus. Again, here you don't want to use your A1C because we talked about it, about the recent turnover and transfusions and everything that might interfere. Okay. So coming back to the staging of the type 1 diabetes, because more and more studies from Finland and European countries have reported that the rate of progression of diabetes is dependent upon the age at the first detection of the antibodies, the number of antibodies, the specificity, and the antibody titer. So they have stressed on this one because this could be an this could be an area where future research and regulatory decision making can be employed. So this is what it is: stage 1, stage 2, stage 3. Stage 1 is autoimmunity. Patients are still normoglycemic and they are usually asymptomatic. And there are multiple antibodies, but there is, as we said, there is normoglycemia, so there is no impaired glucose tolerance or no impaired fasting glucose. And stage 2, we're talking about type 1, so it's autoimmune, and there is dysglycemia, meaning you would start to notice some changes in your fasting blood, your finger sticks, and they're still asymptomatic. And stage 3, here they are overtly symptomatic. New onset hyperglycemia, symptomatic, diabetes by standard criteria. This is stage 3. So they have come up with these recommendations or with this staging because if we are able to target or catch the population in these stage 1 and 2, we can offset many clinical complications. So this is one thing that they have stretched, and it would repeatedly come across throughout your guidelines regarding the patient-centered collaborative care. Lifestyle management and psychosocial care, they have been stressed in this, in the new guidelines specifically. More so, there are certain things that they have added here. At the time of the diagnosis, comprehensive medical evaluation and assessment of comorbidities was suggested in the earlier one. And this one, they went ahead and they went a step ahead and then added some more recommendations. Immunizations, of course, we know are flu, pneumonia vaccinations, and hepatitis B is one thing here. It is a level C recommendation that all diabetics less than 65 years of age should be given, should be offered hepatitis B, because diabetes and hepatitis B more risk of fatty liver disease. And then more than 65, they might be, you can consider it. And then screen for autoimmune disorders, specifically other autoimmune like Hashimoto's, vitiligo, B12 deficiency, all of those. And then cancers, it could be a composite, effect, because diabetes is usually associated with, your other metabolic syndrome kind of thing like hypertension, obesity, dyslipidemias. So this could be a composite, factor. And fracture risk, of course, they're more at risk of fractures. And then in these patients, you would want to use glucose transporters and your glitazones very cautiously, because they are known to increase your fracture risk. And then cognitive impairment, HIV. So this has been put forward again. Patients who are started on HIV treatment should be tested for or screened for diabetes 3 months post-treatment, post-initiation of treatment. And again, hearing impairment, more predisposed. So obstructive sleep apnea. So they have, this is one guideline, one place where they've said, they've recommended that assessment of sleep pattern and duration should be a part of your medical assessment, because recent evidence has been suggesting that glycemic control is affected by your sleep patterns. And then this is one other area, mental illnesses. So screening for mental illnesses and then taking care of them or referring them at the appropriate time. So screen the patients for anxiety, depression, eating disorders, and bipolar disorders. We should screen for them, and also we should keep them in our mind, because most of the medications that you use for bipolars, like your atypical antipsychotics and all those, they have a concomitant risk of hyperglycemia. So you would want to think about those. Lifestyle management. So I came to know recently that our hospital here has a volunteer or is in the program of is involved in these programs. So this should include, any diabetes care should include diabetes self-management education, we call it DSME, and diabetes self-management support, medical nutrition therapy, physical activity, smoking cessation counseling, and psychosocial care. So as much as pharmacotherapy is important in controlling your blood sugar levels in your patient, so we should incorporate all these into our clinic visits. So let's go over these DSME and DSMS programs. They facilitate the knowledge, skills, and abilities necessary for optimal diabetes self-care. So notice they stress on the fact of self-care, because this is empowering the patient or enabling the patient to enhance his or her skills of managing her diabetes, their diabetes. So when should they be referred to these programs? At diagnosis, okay, and then annually for assessment of education, nutrition, and emotional needs to see if they have been met or any intervention needs to be done. And then as and when a new complicating factors arise that can influence their self-management, say physical limitations, health conditions, or emotional factors, or basic living needs. And then when transitions in care occur, which as being a residency training program often happens. So, so the DSMNE, these programs again, the main objective is to support informed decision making. Here the patient is at the center. So self-care behaviors, problem solving, and active collaboration with the other members of your healthcare community. And then medical nutrition therapy, so any patient, any newly diagnosed diabetic or any diabetic should be referred to a registered MNT therapist. That's a level A recommendation. So for obese patients with type 2 diabetes, weight loss more than 5% is needed to produce any kind of beneficial outcomes in the glycemic control, and definitely sustained more than or equal to 7% weight loss is very optimal. And further, the studies have shown that referring a patient to a dietitian or a nutritionist is associated with an A1C decrease of 0.3 to 1%, and with type 1 diabetes, and 0.5 to 2%, which is very significant here. And so most of these recommendations, regarding the physical activity, have been continued from the prior guidelines, but stress has been placed on, due importance has been given to flexibility training and balance training. That is recommended at least 2 to 3 times per week. And also, and this one should engage in 150 minutes or more of moderate to vigorous intense activity per week. They should be spread over at least 3 days per week, not breaking more than should not go without physical activity by more than 2 days. So I'm blanking out here. So they did put in one recommendation that they now recommend prolonged sitting to be interrupted every 30 minutes with short bouts of physical activity. I don't know how far it's feasible. It's feasible for us, definitely. We rarely sit on the floors, but in other professions, the feasibility needed to be accounted for. Right. So again, so we went ahead and screened for prediabetes, came out with guidelines for prediabetes and diabetes. So why do we need those? We need those to initiate interventions to prevent or delay the time of onset of diabetes, right? So lifestyle interventions. So diabetes prevention program is been ongoing, and the recommendations are being added to the guidelines every year. So intensive lifestyle intervention, they could reduce the incidence of type 2 diabetes by 58% over 3 years. Which definitely includes a minimum weight loss of minimum of 7% weight loss, and again 150 minutes of physical activity per week. And pharmacological interventions. So we've been using more and more of metformin in our clinic. So should be considered in those patients with prediabetes, especially for those with BMI more than 35 and less than 60 years, women with prior gestational diabetes, and those with rising A1C, say 5.7 to 6.4, and it's continuously rising despite lifestyle interventions. So this is a level A recommendation. And this is a new one which we need to stress upon. I didn't know this one too before. So long-term use of metformin, recent studies have shown that it has been associated with low vitamin B12 levels. So periodic testing for B12 should be employed, especially in patients where you're concerned with neuropathy. I know diabetes, neuropathy, we have an obvious reason there, but make sure that you make it a point to check your B12 too periodically. Okay. So other pharmacological interventions here in the stage of this diabetes, like your liraglutide and your glucose transporters, they have not been FDA approved, but they are still in the consideration to use here. And recommendations for glycemic targets, which should include your continuous monitoring of your glucose by self-monitoring of the blood glucose by the patient at home, which is very finicky for us to get it, and then A1C. So there is no set duration as when and how often do you need to test your A1C to monitor your glycemic control. So they say definitely, recommended at least, which is level E of course, which is recommended at least, even those stable diabetics, at least twice every year, like every 6 months, and in patients who have not met their goals, at least quarterly. So this includes, this is the table that has been carried over from the 2016 guidelines. It just correlates your A1C levels with the mean plasma glucose levels, which is a nice thing to know, because when you are sitting with a patient in the clinic, you do not want to wait for your A1C. Maybe it can just give you a rough estimate so that you would want to maybe change your therapies based on that one. And the glycemic targets, A1C less than 7 all the time. And it gives you like the blood glucose levels corresponding ones, 80 to 130. So more or less stringent glycemic goals, it all depends upon your patient and his other concomitant comorbidities and his age. So less stringent ones, like up to hemoglobin A1C of 8 could be your target based upon your life expectancy and other comorbid conditions. And of course your hypoglycemia awareness. You do not want to be aggressive in a patient, more elderly patients who are cognitively impaired, who are at a risk of hypoglycemia and they're unaware of it. So it's okay to be lenient there, and then your A1C goal to be around like 8 at that point. I should include here that your glycemic targets for A1C during gestational diabetes should be less than or equal to 6.5, it's not 7, for better maternal outcome and fetal outcome. So this is a new recommendation, new inclusion too. They've given out hypoglycemia awareness and new critical value for hypoglycemia. So alert value is your blood glucose level less than or equal to 70, and where it is sufficiently low that you need to maybe change your treatment strategies. And then clinically significant hypoglycemia is less than 54, which is again defined by the need for assistance of somebody at that point of time for anything. So this should be a critical value less than 54, and then it's very sufficiently low to indicate serious. So critically important changes has to be made in your regimen. So obesity management for the treatment of type 2 diabetes again, it should include diet, physical activity, and behavioral therapy. Diet we went over again earlier. So it has come up with recommendations including fat. It used to be only carbohydrate counting before. So recommendations have ensured fat and protein counting too towards your caloric intake and your insulin adjustments. And pharmacotherapy, at least 5 of these drugs have been FDA approved: orlistat, locazarine, phentermine, naltrexone, and liraglutide. So this liraglutide, it is your Victoza, usually that we use in the treatment of diabetes, but this the liraglutide that is used for treatment of obesity, it comes at an increased dose by the name of Saxenda. It's 6 milligrams doses, that's injectables. And then this is one thing, so bariatric surgery is not a term anymore, it's metabolic surgery from here now on. So they want the bariatric surgery to be called as metabolic surgery. And then they have changed significant recommendations. I mean, change in recommendations have come regarding who can be referred for metabolic surgeries. And of course, again, you have to think about the cost and associated risk and longer term complications like your dumping syndrome, vitamin deficiencies, anemia, osteoporosis, and hypoglycemia. So this is your recommendation for your diet, pharmacotherapy, and metabolic surgery. So you should notice that here, starting from, depends upon, Asian Americans 27.5 and BMI of 30, it is a new guideline for starting referring patients for metabolic surgeries. And pharmacotherapy, 27, you can start initiating at or more than 27 BMI. And diet, physical activity, and behavioral therapy at every stage. This is again just the same thing, physical activity with the level of recommendation, A and B. So here with the pharmacological therapy for type 1 diabetes. So more studies have been come out that we see patients who are type 1 diabetics who are just on long actings. We've seen that such patients in the hospital. So these recent studies suggest that they should be treated with multiple daily injections of prandial and basal or a continuous pump. It's a level A recommendation that has been shown to have better glycemic control. What are the pharmacological agents for type 1? Insulin again, pramlintide, which is an amylin analog, pancreas and islet cell transplantations can be considered. Investigational agents, metformin. I should ask Dr. Levine. Do we use metformin, Dr. Levine, often in type 1? Not routinely. Not routinely. But maybe in some obese individuals?
Some of the type 1s, as they get obese and develop insulin resistance from other causes, we might consider, but generally not.
Because we've been seeing some patients with type 1 diabetes with obesity on metformin, like in inpatient hospital admissions, and this is definitely not an FDA approved yet, but more evidence is leaning towards it. And then again, your incretin-based therapies, like your GLP-1 agonist, like your Byetta, Victoza, DPP-4 inhibitors, or your gliptins. And then sodium glucose co-transporters too. They provide insulin-independent glucose lowering by blocking the glucose reabsorption. So these can be used on a case-by-case basis, but have not been well approved, FDA approved. So a word of caution with these co-transporters is the reporting of more and more incidents of severe ketoacidosis. So type 2 diabetes, again, level A recommendation. If not contraindicated and if tolerated, all the patients, initial treatment of choice should be metformin. And then again, we talked about your B12 levels, so periodically check your B12 levels in patients who've been on chronic metformin therapy. And again, if non-insulin monotherapy at maximal tolerated doses does not achieve or maintain your target within 3 months, you can add a second oral agent, a GLP-1-like peptide, or a basal insulin. So it's not that you have to wait to optimize all your orals before you want to do your insulin therapy. This again, depending upon the levels of recommendation, the same thing. We're going to go over this one in the next slide. So this is one other area where they have included, stressed on this one, who have been having long-standing or suboptimally controlled diabetes with an established or at risk of severe ASCVD, your glucose transporters, and your incretin analogs, they should be considered in the treatment because they have been shown to reduce your cardiovascular disease outcomes. We're going to go over it in the next few slides. So these are the two prominent trials that have been done in regarding your glucose transporters. It is EMPA-REG outcome. It has come out in 2015, both of them actually. So randomized double-blind trial that assess the effect of the drug versus placebo and standard care on cardiovascular output with type 2 diabetes and existing cardiovascular disease. And this has shown, and this one is this is all inclusive of the population, typical population that we see. Mean age is 63, 57% had diabetes more than 10 years, and the 99% has already established disease. And over a median follow-up of 3.1 years, it has been reduced by the ASCVD outcome by the MI, stroke, or any cardiovascular death by 14% in your placebo group versus 38% in the treatment group. And the other one is your LEADER study. This has also come out in 2015 in the NEJM. Again, it looks at the effects of liraglutide and the evaluation of the cardiovascular outcome. It also shows a significant the outcome is 13% as opposed to 15% in your placebo group. And then the other studies and trials have been done in regards to your other medications, but no significant difference was found with regards to cardiovascular events. So before we go into the therapy, just action of various sites of action. I'm sure we are all familiar by now. Glucagon secretion is incretins act by decreasing the glucagon secretion, and amylin, which is pramlintide, sulfonylureas, meglitidins, and incretins again, they increase the insulin secretion. And at the level of GI, we can use your alpha-glucoside inhibitors, amylase, bile acid sequestrants. So these three groups are not routinely that we use in our treatment of diabetes in our algorithm. They can be considered. And by decreasing the hepatic glucose output, your thiazolidiones and your metformin, and then your lipotoxicity, again, this one, glucose uptake and utilization, which is targeting your insulin resistance, metformin and thiazolidiones. And at the level of kidney, again, your glucose transporters, co-transporters. So this is a very busy slide, but it essentially says the same thing. So A1C greater than or equal to 9% at the time of diagnosis, consider dual therapy. A1C is greater than or equal to 10%, or the blood glucose more than or equal to 300, or the patient is symptomatic. You do not want to wait for optimization of your oral before you want to start on insulin. You can start ahead on insulin therapies. So monotherapy, again, metformin. So lifestyle management is a part and parcel of your diabetes management with the patient. So high efficacy, low risk of hypo again, neutral to maybe some weight loss. Side effects, very minimal. Most commonly is their intolerance, the famous one that we hear. And then lactic acidosis in some patients. You would want to use it with caution in CKD patients and your CHF patients and your liver disorders. So more and more evidence has been coming forward that you can use your metformin, providing you monitor their creatinine after starting initiation of therapy with GFR as low as 30 to 45% too, and in stable stage to class 2 your heart failure too. And then dual therapy, metformin plus any one of your all these your drug choices. So left to right doesn't mean this is a preferred choice that you need to make. It has just been given out this way just because of their historical availability. So you can practically use any one of them in any order, right? So metformin again, so it goes on in detail regarding again all the same 5 factors here. So at least in our practice scenario over here at LSU, you would want to think of the most important thing is your cost factor, right? So definitely sulfonylureas and thiazolidiones. Your DPP4 inhibitors, we most commonly we are not using it. It requires again prior authorization, it being your from the Medicare 2 actually. And all these are very costly again. So the target has not been achieved after 3 months of dual therapy, then you use a 3-drug combination, a triple therapy. If even that has not been done, then definitely go over and start insulin. So again, this is a neat flow diagram regarding how to adjust your insulin too. So a patient who is very cognizant enough and who can do home glucose monitoring, you can employ this one in controlling or his blood sugars he need not wait until he sees us every so often, like 4 to 6 weeks, right? So initiate basal insulin, usually with metformin plus or other non-insulin agents. Usually any basal insulin is at no risk of hypoglycemia. So even if the patient is on other hypoglycemics like your DPP-4 inhibitors, sulfonylureas, thiazolidinediones, any of those, you can still go ahead and start your basal insulin. So you start 10 units per day or 0.1 to 0.2 units per kg per day. How do you adjust it? So for your targets, your blood glucose targets, you can actually slowly go over either 10 to 15% of your starting dose or 2 to 4 units once or twice weekly. So that's how you monitor your sugars. And if your fasting blood glucoses are not in your optimal range, meaning they're still more than 130s fasting blood glucoses, so you would want to increase it by the said percentage. And then any hypo, so you determine as to what are the other causes of the hypo that can be ruled out. And then if none can be found out, then you should decrease by 4 units or 10 to 20%. So it's still not controlled, then you can consider any injectable therapies. So you can use it, not necessarily in the same order, like using your prandial three-time insulin coverage. You can actually use your GLP-1 receptor antagonist, like your incretin analogs. The same thing again, so your rapid injecting, if you want to use that one, so if you're using only one, that means you would want to see the patient the biggest meal of the day. If you want to start that way, then you can use 4 units or 0.1 units, or you can start out with 10% of the basal dose of how much the patient was taking. Again, the patient can adjust him or herself by increasing the dose by 1 or 2 units or 10 to 15%. So here is 2 to 4, 1 to 2, or 10 to 15%. So these are interchangeable, mixed again, so 70-30 pre-mixed insulins too. And if still not controlled, then you would want to use your basal bolus regimen, 3-time regimen. So this is a very good chart. It really helps in monitoring or up titrating the glucose insulins. So this is one area where do you stop the other hypoglycemics when you started using your basal insulin? So sulfonylureas and DPP-4 are usually withdrawn with more complicated regimens, like you're using basal bolus thing, then more severe risk of hypoglycemia. So you would want to usually pioglitazones and glucose transporters are still okay to use with caution. So management of diabetes in pregnancy. So we went over the disease diagnosis, and now we're going over the treatment. How do you manage? Again, patients who are already diabetic, and they should be given counseling, preconception counseling starting at the age of puberty. That's level A recommendation. And then family planning should be offered or be discussed. Preconceptional counseling, and then every patient with diabetes planning to get pregnant should be screened for retinopathy and should be cautioned against worsening of the same. And gestational diabetes specifically, we started, this is level A recommendation. Of course, lifestyle changes again, big thing. Medications should be added if needed. And we've used to see more of insulins. Then there was a shift to using metformins and your sulfonylureas. But again, recent studies with recommendations again suggest, since the efficacy, the long-term efficacy of this one has not been out or has not been well studied, it is still reasonable to use insulin in treating of your hyperglycemia during pregnancy. So that's one change that they have come up with. So metformin, when used to treat the PCOS, need not be continued during pregnancy. If the sugars are high, then you would switch to your insulins. And again, I think we're running short of time. So the other one again talks about your microvascular complications. Your macrovascular, meaning your atherosclerotic vascular diseases, MI, your ACS specifically, stroke, TIAs or peripheral artery diseases, and you would want to include your screening for risk factors for dyslipidemia, hypertension, smoking, and your premature family history of premature CAD and presence of renal complications like albuminuria. So hypertension again, 140/90 goal. Sprint trial has come out for more aggressive blood pressure targeting, but sadly they have not included diabetics in them. So we cannot take those, at least in these recommendations, we cannot take those into considerations. And hypertension, like everywhere else. So reduce sodium diet, moderate alcohol intake, increase physical activity. So blood pressure target should be 120 to 160, 80 to 105. More aggressive lowering of diastolic pressures in older population associated with severe, bad outcomes. So that is not recommended. So this is one area of recommendation. Focus on this one. They've included, apart from your ACE, ARBs, and thiazide-like diuretics, they also included dihydropyridine calcium channel blockers that can be used as your initial therapy. So this is one of the new ones. So I'm just going to go skip by fast and then make sure to point out which are the new ones. Okay. So lipid management again. Nothing much has changed from the previous guidelines, again focused on weight loss and reducing intake of saturated fats. The same thing went to recommend, again, if you notice this is from 2016 again, so nothing much has changed here. When do you want to start a statin? Less than 40 years with no risk factors, then none, then ASCVD risk factors. We know what we just went over earlier. Then you moderate to high intensity statins. 40 to 75, moderate to high intensity statin, depends upon no risk factors to ASCVD risk factors with ASCVD. And less than 75, just a regular recommendation. So usually moderate to high intensity statin, anybody more than 40 years of age, depending upon presence or absence of your ASCVD risk factors or ASCVD per se. So this is a slide of what include high and moderate statins. They come out with these based upon their ability to lower your LDL levels. So 30 to less than 50% is your moderate intensity statin, and is almost more than or equal to 50% lowering capacity. So lipid management, focus on these next two slides because new recommendations suggest adding of ezetimibe to your moderate intensity statin therapy in patients who is not able to tolerate your regular statin therapies or where we cannot use maximal dose. So this has been proved by the IMPROVE-IT trial. So ezetimibe, yes. And combination of a statin and fibrate, not necessary to decrease your ASCVD outcomes, if needed only to decrease your triglyceride levels. And then this one is another recommendation that you want to notice, statin and niacin not to be used, recommended not to be used because of risk of stroke. And then this is one other recommendation too, new one, the PCSK9 inhibitors. Not much studies have been done so far because they are still in phase 4 trials. So, but at least initial studies have shown that combination of inhibitors, PCSK9 along with your statin, can decrease the reduction your LDL to 36 to 60%. So again, to use statin with the risk of hyperglycemia, because statins are known to increase the risk of your glycemia, like blood sugars. So this is just to point out that after meta-analysis of 13 randomized controlled trials, after 4 years, for every one additional case of so many number of patients, almost 100,000. They see that only odds ratio of 1 new diagnosis for 255 patients, as opposed to 5.4 vascular events occurring. So still, risk versus benefits, you would want to use statin in spite of hyperglycemia. And antiplatelet agents, nothing much has changed. Aspirin when you can, less than 40, more than 40, depending upon your risk factors and your calculating score. Where you can't use aspirin, please use Plavix. And gel therapy after your ACS or any event for up to 1 year or more is recommended. And then your screening, nothing much has changed over here. Kidney disease about the same. Look for your albuminuria. Anybody who's diagnosed with type 2 diabetes and type 1 diabetes for more than 5 years. And then you should use your ACE or ARBs then. Then retinopathy, the same thing, 5 years after type 1 and type 2 diabetes. So neuropathy again, so different kinds of neuropathy, diabetic autonomic neuropathy, which can cause hypoglycemia unawareness, gastroparesis, constipation, your neurogenic bladder, erectile dysfunction, and pseudomotor dysfunction. And specifically cardiovascular autonomic neuropathy, this is independent of your other risk factors. So how to detect it is to watch out for resting tachycardia and orthostatic hypotension. And then these are the drugs that have been FDA approved: pregabalin, cymbalta, tapentadol, which is an opioid agonist. But the rest of them have been tried, but not FDA approved. Foot care again, when do you screen them? Every year with your monofilament test, and with a history of foot ulceration, amputation, deformities, your Charcot's toys and everything, special notice to be given to those. And when to screen for your peripheral arterial disease? In patients more than 50 years or less than 50 years with PAD risk factors. I'm not too sure we've been doing this one unless the patients are symptomatic. And again, your CAD, CHF, routine screening has not been again recommended. With risk factors, yes. With symptoms, yes. And CHF, again, metformin can still be used, and we talked about even less than more than 30 in CKD patients. So this is one patient, one area where they have stressed again diabetic care in the hospital to be transitioned to outpatient setting. So inpatient glucose targets 140 to 180, can be less than 140 without significant hypoglycemia. So please focus on this one. We tend to do this most often, putting a patient on sliding scale with no basal coverage, which is an absolute no-no. It's a level A recommendation. So a basal plus correction insulin regimen is a preferred treatment. And of course, your carb consistent diet goes along with it. Okay, so level A recommendation again, level B recommendation again to order an A1C if has not been done within the 3 months, even if the patient is in the hospital, and an immediate follow-up within the next month to be followed outpatient. Okay. I'm sorry, I had to rush in the end, but not much has changed over there. Any questions?
Hi, everyone. In neuropathy, how often is it just pure numbness versus painful neuropathy? The reason I ask is, at least in oncology, when we use drugs that cause neuropathy, many times it's just numbness, no pain, and then you still see them being put on pregabalin and gabapentin, which don't improve neuropathy, they improve painful neuropathy, and you then get some new side effects. So I don't know if it's the same with diabetes, but we try to teach our people to ask, just not say, oh, they've got, Christine-induced neuropathy, start gabapentin, but they ask what the symptoms are. Right. How often do you see just pure numbness in diabetics?
I'm not too sure about the percentages, but most often they end up with painful neuropathy just because they neglect or fail to follow with a physician. So the important thing to concentrate here is, we can use those medications just for neuropathy without pain, like I said, numbing and tingling and numbness.
How does it help?
It doesn't help because those neurological loss is irreversible. So it only helps symptoms. So again, this is where you would want to.
That's why I think it's important, because I've seen so many people, they see the word neuropathy and they automatically prescribe the medicine without seeing if it can help, and if it's pure numbness, it's not going to help.
It's not going to help.
It's going to make them groggy, they took down the steps there.
You're right.